Should we start? Deepak, should we start or
Yes,
two,
yes, ma'am.
two,
We
three
can
minutes
start.
should we wait?
People are joining. I think we can start,
And
but ma'am, at least
okay,
introduction.
okay. So good morning, everyone, and welcome to this MRA session of antibody tests in rheumatology. So nowadays, we actually encounter many patients in OPD who come with lab reports of ANA positive, rheumatoid factor positive, and they come and say, Doctor, please treat my ANA and please make my rheumatoid factor negative. मेरा rheumatoid factor negative कर दो. And when you actually see them, you take a detailed history and do a clinical examination, you find that they don't actually have an inflammatory arthritis or a connective tissue disease. And they are the result of a panel of tests which contain all antibody tests like rheumatoid factor, anti-CCP, ANA, HLA-B27, uric acid. And they're done just because they have some aches and pains. And that actually leads to many false positive, a lot of patient anxiety, a lot of consultations and increased cost. We see that, most of the times, 95% of the diagnosis is actually clinical examination and a good history. And lab tests are just support or help in classification of disease or prognostication. But they do have a lot of importance. But they are more important when they are done with a high pretest probability. So today we have Dr. Sanat Phathak who will guide us when to do the test, in which conditions to do it, when do you suspect, in which diseases to do which tests, and when they do come positive or even if they do come negative, how to interpret them in context to the clinical picture. So Dr. Sanat is a DM rheumatologist. He's practicing in KM Hospital in Pune and also in BJ Medical College, Sassoon Hospital as a visiting consultant. And he has done DM in clinical immunology and rheumatology from SGPGI Lucknow. And I remember when we were residents, we used to look up to him. He was like a perfectionist. And like how we say in medicine, he's walking, talking Harrison. So he used to be a walking, talking Kelly Hochberg. And he has carried that forward even today. And apart from his academic accolades, he is a brilliant rheumatologist. His dedication and hard work has even inspired other medical students to take up rheumatology, which, in my opinion, is the biggest achievement. So, without further ado, I invite Dr. Sanat to please carry forward and deliver his talk on antibody tests in connective tissue disease. Sir.
Hi, thanks, Natasha. Good morning. Thanks
Mm.
everyone for joining on a very warm Sunday. I'm going to go right into it. We'll hopefully be able to take questions later. If you'd like, just stop me in between if you would want to clarify something then and there. And in the interest of internet bandwidth, I'm just going to put off my video now. But whenever you want to say something, just raise your hand. Yeah. Okay, so like Natasha said, we are going to talk about lab testing, and I'm going to focus a little more about autoantibody tests in connective tissue disease. Some residents may have heard this more or less the same, some changes last year at KEM in Bombay. But it's always good to think about how we are ordering tests and how we are interpreting them because it changes both spending and how we think of things and how people think of us as well as their diagnosis. So even for the patient, it makes a difference. Right. So I'm going to start very, very simply or very proximally to say that connective tissue disease is used from what I see, what we see medicine residents or even the students say, is connective tissue disease is used very, very vaguely. So we need to make a change in that. It's almost like an MBBS answer. If you ask somebody what connective tissue disease means, They'll say that they are problems in the connective tissue. So that is tissue in between two organs or in between two functional cells. And these can be genetic, let's say like Marfan's, or it could be connective tissue infections, like let's say flexor synovial infection in tuberculosis, or it could be nutritional problems in the connective tissue, like happen in scurvy, etc. And while this is correct, at one level, we are not going to talk about all of these things. So, general umbrella is not the connective tissue disease that we are talking about. We are talking about actually a specific set of multi-system autoimmune disease, right? So, all three words are important here. So they are autoimmune diseases. Where obviously there is self recognition of or recognition of self tissue by at least one part of the immune system, and then there are multi-system diseases. So that's what makes a disease a connective tissue disease. And like I said, it is not a vague terminology. It's actually just six diseases. So rheumatoid arthritis, Sjogren's, lupus, systemic sclerosis, dermatomyositis, and polymyositis. These are six clinical syndromes. They are not antibody diagnosis, as will come later. They are not uh, something that are vaguely diagnosed just by basis of a test, right? And anything apart from this is not really a connective tissue disease. There can be some other things. For example, you can have features of three or four diseases and and the presence of a particular antibody, which is RMP. Then you would call it mixed connective tissue disease. Again, this is one term that we see being overused widely. Any patient, just because they have, let's say, a patient with lupus has Raynaud's, we see them being called mixed connective tissue disease. Lupus can have Raynaud's. So the mixture is a very specific clinical scenario in MCTD. And if you find that there are features that are specific to one disease, for example, there is deforming arthritis, like you'd see in rheumatoid arthritis, and you don't see in lupus. And if you see deforming arthritis in a patient with lupus, then there is a true overlap between two specific different conditions. So then is when we would call it overlap connective tissue disease. And thirdly, we often need to invoke this term when the disease is starting off. Maybe in the first year or so, it doesn't truly look like rheumatoid arthritis or lupus or a Sjogren's. It's just started off with vague symptomatology, arthralgia, some kind of rash which could be present in either of these, and ANA being positive, etc. Then it's best to call them undifferentiated connective tissue disease, because an open label is good in these conditions, and then we keep a watch to see if they are evolving into going into something else. Right. I'm also going to talk about a little bit about vasculitis, although they are not traditionally termed as connective tissue diseases. But at least some of the vasculitis, especially the small vessel vasculitis, are associated with antibodies. So I'm also going to talk about that. The large and medium vessel, you should remember, are not associated with antibodies. And like we said, these are systemic autoimmune diseases. So again, a problem in clinic comes when everything that is autoimmune is referred to us. And we struggle to tell people that non-systemic or organ-specific autoimmunity, which is on the left side of this spectrum diagram in the brick red color, is usually treated by the specialist who looks at that organ. For example, Hashimoto thyroiditis is a prototype organ-specific autoimmune disease. It is definitely autoimmune, but the autoimmune response or the immune attack is on one particular cell or one particular antigen within the thyroid. Which is either TPO or thyroid globulin or whichever else. So all you need to do is replace thyroid hormone, and you don't really need to immunosuppress. In some, you do need to immunosuppress, like for example, multiple sclerosis. But again, it is specific to one type of tissue or one type of organ system, and these are therefore not considered under connective tissue disease which is harking back to the initial classification that we were saying. So we all know that SLE is the prototype of a systemic autoimmune disease because virtually any system under the sun can be affected in SLE, and we know what all can be affected and how it can be affected. That's easily possible, but it's also important to remember that the other five connective tissue diseases, although we think of them in one particular way, are also truly multi-system disorders. For example, rheumatoid arthritis, chiefly or maybe or it presents with synovial joint inflammation, but patients may have other involvements such as lung, they can have vasculitis, they can have peripheral neuropathy, etc. Again, with Sjogren's syndrome, there is a chief involvement of the exocrine gland, which you need to classify them as Sjogren's, but other organs are involved. Systemic sclerosis, again, skin and lung are the main things. The myositis, inflammatory myositis, muscle is the main thing, but other tissues can and are involved. So A, you don't want to miss involvements of these tissues, and B, you don't want to mislabel these as organ-specific autoimmune disease. And manifestations of connective tissue diseases may be different according to who is looking at them, right? So it's like the traditional tale which comes from, I think, Jain philosophy, where seven blind people are looking at an elephant and each will describe the elephant in a very different way. Blind man looking at the tusk will think the elephant looks like a spear, and blind man looking at its tail would think it looks like a rope, and then there's a chance that they might fight with each other, saying that this is what an elephant looks like. So similarly, a connective tissue disease may present to virtually anyone. Any specialty can get a connective tissue disease being presented to them. And again, depending on the specialty, they'll look very different. For example, um, we've had patients with lupus who presented first to general surgery with a young onset pancreatitis, and then you go and see, and there's a malar rash or other manifestations which nobody had even noticed lying in the general surgery ward. And they can present to neurology with young onset stroke. They can present very commonly to dermatology with certain particular rashes, obstetric gynecology, what have you. I don't think any specialty is spared in detecting or having a suspicion of a connective tissue disease coming to them. And that's why it's doubly important for you and every specialty to think about how we investigate these people, how we confirm what we are labeling them as, why we are labeling them, so how we are going to monitor them, etc. So it's always very useful to think that how do lab investigations help? We always need a goal for a lab investigation. It's an expensive test often, and without a goal, it usually is a waste of money. Or a connective tissue disease, the lab investigations that you are going to do have a few particular goals. A, to demonstrate that this is an autoimmune disease. And to demonstrate these, you have autoantibodies or you have a biopsy to say that there is immune cell infiltration into self tissue, and therefore this is probably autoimmune. B, you want to demonstrate inflammation, which is to say that autoantibodies itself only demonstrate autoimmunity and may not really translate into inflammation in everyone. So you might have about 10% of the population to 20% at a certain age being positive for ANA, which demonstrates antibodies, but not inflammation. So it doesn't mean that there's a disease, but if you demonstrate inflammation, then what is this? Okay, Deepak has said. Then you know that the immune system is actually attacking one particular organ or one tissue. A biopsy again will demonstrate this. see, and what is most important for me, or what is most important to decide how much treatment a patient needs, is to investigate to with the goal of delineating the extent of disease. So you'll see if a person comes with a malar rash and is an ANA positive, you'll see if they have renal involvement, and if they do, they'll have a very different disease trajectory as well as very different drugs that you're treating them with as compared to someone who has just malar rash and no organ involvement. So to decide the treatment, to decide which medication you're going to start, this is the most important group. Once the disease is diagnosed, these patients will keep coming back to you, and you don't need to diagnose them again and again. So we see that patients are repeating many uh, tests that were done at diagnosis and with the goal of diagnosis. So once it's diagnosed, you don't need to diagnose them 3 times in a year. So the goals of how lab investigations help once disease is diagnosed are threefold. One, to monitor disease activity, and that is to say how much inflammation there is usually, or depending on the organ involved. For example, if it's a patient with lupus nephritis or ANCA vasculitis with renal involvement, then you want to see if there's a urine sediment, etc. Then these patients are on immunosuppressant medications, which could be toxic in a particular prevalence. They are on steroids, so you want to look at those particular side effects, etc. And the third one is to look at any comorbidities, because a patient with, let's say, psoriatic arthritis is more commonly associated with diabetes than someone who isn't. So you need to know these associations and uncover comorbidities to be able to treat them holistically. I'm going to talk a little bit about autoantibodies first, and talk about what the principle of management of measurement is, how they are measured, what you are truly looking at when you are measuring these autoantibodies. So very simply, just go back to say what is an ANA. An anti-nuclear antigen is essentially that, right? It's an antibody against something in a human cell's nucleus, right? So the red antibodies on the diagram on the left will recognize tissue, recognize some antigen in the nucleus that is marked inside the cell in the red. And these are pretty non-specific because usually nuclei all across all cell types, except of course RBCs, platelets, will have a more or less similar looking structure, right? Of course, make sure that the antibody can't go inside the cell, so the nuclear antigens have to be outside the cell for there to be really binding to the nuclear antigen. Then you would want to see which nuclear antigen. The nucleus is not just full of sand. It's not one particular type of tissue or one particular type of protein, but the nucleus is a working machine, and it's got DNA, it's got histones, it's got ribosomes, it's got enzymes, it's got nuclear complexes. Yeah, there's a whole host of things within the nucleus, and the antibody, the ANA, is actually usually against some specific antigen, right? So when are actually ANAs. ANA and anti-dsDNA often are talked about as separate things. Like this person has ANA positive, but not anti-dsDNA positive. This person has anti-dsDNA positive and not ANA positive. Those kind of things. Those are not two different tests. Anti-dsDNA is actually an anti-nuclear antigen. It only tells you that the antibody is against the DNA. I mean, you can have an ANA positivity and not an anti-dsDNA positivity because the ANA is then not against the DNA, and it's actually targeting maybe histone or maybe ribosome, etc. The easiest way or the most traditional way of testing for this is a technique that we call immunofluorescence. Immunofluorescence is the following. So let's say you have this patient with lupus, you get a serum sample out of her. The serum sample obviously is going to have anti-nuclear antibodies. You put them onto a cell that you have fixed on a slide. The nucleus is inside the cell, so they are not going to go in directly or they're not going to bind. But if you permeabilize the cell, which is seen in the second panel of the diagram, then the antibody can go into this permeabilized cell and actually bind to the nucleus because it recognizes it. Then what you do is put in another antibody, which is against anti-human immunoglobulin. So it's going to bind any human globulin only, which is labeled with a fluorescent molecule. If that antibody binds to the ANA, which is bound to the nucleus, then it will get fixed there. And when you shine a fluorescence light on it, only that tissue is going to fluoresce, right? So this is essentially what how immunofluorescence is helping you detect the presence of ANA, which is present in the patient's serum with the basis of a cell that you have fixed on a slide. And which tissue could you use to fix on a slide? You could virtually use any tissue which has nucleated cells. So apart from RBCs and apart from platelets, you can use any cells. What we have been traditionally using is rat liver or even primate liver because it's a practical decision because one slice of the liver gives you many nucleated cells. Whereas, let's say if you use lung tissue, then they are few and far between, and there's air spaces, so it's just practically inefficient to use something that does not have a lot of nucleated cells. So we've been using liver. And now look at the diagram on the right, where you see that within the cells, the nuclei are lighting up. So you can see a darker green outline of the cells, but you see a lighter green, more bright immunofluorescence in the actual nucleus. And so therefore the serum that was poured onto this section had ANA positive because we know that it's bound to the nucleus, and after that the immunofluor has bound to that ANA. Okay, please feel free to stop me if you find that anything is unclear. What we have been using more recently is malignant cells. Again, a practical decision because the nucleus is what we are interested in, and malignant cells have huge nuclei. So why waste that chance? So they don't have much cytoplasm at all. As you know, one of the defining features of a malignant cell is a high NC ratio. So we leverage that NC ratio to see that if there are large nuclei, we might be able to see within the cell, within the nucleus. And here now, because they are large nuclei, you can make out particular patterns within the nucleus, right? So, for example, on the right side, you see an ANA immunofluorescence, but the nucleus have been stained in a particular manner, which we call homogeneous. It's homogeneously distributed all across. What about this? What are we looking at here? Again, we are looking at immunofluorescence. If you look at what you see on the left, you see that within the nucleus, within the cells, the nucleus is multi-lobed. So you know that it is a neutrophil. And the nucleus is black, and it's actually the cytoplasm which is lighting up, right? So you know that the antibodies are not against nucleus, so they are not ANA, but they are against cytoplasm, and they are against the cytoplasm of a neutrophil. So you know that you want to label the antibodies as anti-neutrophil cytoplasmic antibody, which is ANCA, right? And they are diffuse in the left, so those are fully cytoplasmic ANCA, that's C ANCA, and while they are concentrated around the nucleus on the right, so it's perinuclear. So you see that immunofluorescence is actually a pretty powerful technique where it doesn't limit you to doing only ANAs. It does help you in seeing that antibodies can be against various tissue, even in other sections. For example, here you have a section of an esophagus, and what is lighting up is parietal cells. So you know that the serum that you put on it had antiparietal cell antibodies, and therefore the diseases that are associated. So this is the kind of immunofluorescence report that you see. You will see these four things that are reported. You'll see a weak positive, strong positive, and a 1 plus, 2 plus, 3 plus. This is subjective. So when a person is reading it, when I get, let's say, this sample on the right, I would say that this is not very bright because I've seen brighter. So this is 2 plus to 3 plus. But I might say 2 plus because I have seen a few, and somebody who's seen thousands of samples feels that this is amongst the brighter ones that he's seen, and therefore it is 3 plus. So it's subjective. So 1 plus, 2 plus, 3 plus is not gospel truth. It's subjective on depending on who's seeing. The titer at the end is a big point of contention because we get very animated calls saying that a titer is 1 is to 100 or 1 is to 80. That's fixed by a lab. So any lab will have a starting titer, and it's if you see that it's 1 plus here, but just because it's labeled 1 is to 100 does not mean that it's a very strong positive one. It just says that they've done it at the titer that they have fixed. So if it's 1 is to 1,000, let's say, then they have done more dilutions, and therefore that tells you that there's the antibodies in higher concentrations. And the central thing is the pattern, right? So where you see speckled in the report above, like I showed you initially, the pattern that you're seeing on the left is homogeneous, where it's diffused throughout the nucleus, whereas the report above, the nucleus will look something like this, that within the nucleus, there are multiple tiny speckles. Why this is important is that it gives you an idea about which antigen within the nucleus is likely to be drawing autoimmune responses. For example, if the DNA is spread out homogeneously throughout the nucleus, and therefore that is likely to produce a homogeneous ANA. So I would just venture a guess that the patient on the left has anti-dsDNA antibodies, whereas there are certain enzyme complexes such as RNP, which are discrete molecules, large molecules spread within the cytoplasm of within the nucleoplasm, and therefore they will produce a speckled pattern. So you would think that it's probably one of those. You can have different things. So here, if you count the dots on the left, you will see that there are 23 or 46 discrete dots. And so these are something that we call centromeres. So this patient has anti-centromere and antibodies. Here you see a couple of discrete 2 to 3 dots within the nucleus. So these are nucleoli. This patient has a nucleolar pattern. And here you see that even if you're testing for ANA, you see that the nucleus is not shining. In fact, you see a blackish, dark grayish area in the center, which is not fluorescing, and you see true fluorescence in the cytoplasm. So you know that it's actually, there is autoimmunity, it's against a cytoplasmic antigen. So something like asthma that you see in liver disease, those are cytoplasmic antigens. They are not nuclear antigens. And you don't need to go too much into this, but based on the pattern, there is a whole consensus on how immunofluorescence needs to be reported. So it's pretty standardized now. And the patterns are important, not because they look pretty, but because they have clinical correlates. So why is it important to say that this person is a homogeneous? Because you can make a calculated guess that this patient has anti-dsDNA, and it can either confirm or refute your suspicion of having SL, for example. But this is an older technique, and while it gives you a clue about which antigen within the nucleus, you can be more specific by actually taking that antigen, putting that into a well, and then doing an ELISA. So ELISA is more or less the same as immunofluorescence, where the technique is concerned. Two things are different. The first is you are choosing which antigen to put on the well. So there you had the substrate was a fixed cell, which had all the nuclear antigens that any cell will have. Here, if you want to look at dsDNA only, double-stranded DNA only, you'll just take double-stranded DNA and coat it on the well, and therefore you get a far more specific test. The second difference as compared to immunofluorescence is that there the immunofluorescence was read by the eye. Here there is an enzyme color substrate that happens and change that happens, and that color change can be read by a machine. So you get a titer. So these are the two advantages or changes as compared to immunofluorescence. So, for example, you can do an ANA ELISA also, where you will take the entire nucleus, pound it up, and coat it on a well. Or you can do a specific antibody. Like I said, you can take only the double-stranded DNA, you can take only the row antigen and coat it on the well, which is the leftmost panel above you. And like I said, you get a titer when you'll see any yeah, test being reported with ELISA. The third one, which is very, very widely used, is something called ENA, extractable nuclear antigens, or it's based on a Western blot, so it's also called an ENA blot or an immunoblot. And here, what they've done is taken many common antigens on a strip and then put it up. Somebody's asking which to do, ELISA or IFA. So you will come to that. You will find that answer right away. Are we taking questions now, or should we just wait until the end to take questions?
So we can take at the end.
Okay, fine. So then I won't stop in between. So what they've done is put multiple different antigens on a single strip, and then based on the principle of Western blot, they're looking at which all antibodies are binding to those antigens on that strip. So here, for example, on the right, you will find that this patient has dsDNA, nucleosome, and histone all throughout, shining out, and the rest are all negative. So you can get multiple specific antigens in one test rather than doing separate ELISAs for all. Right. So some principles or suggestions on how we are going to use autoantibody tests when you have a patient. And the bane of our existence is that when we get a phone call and saying that, can you see somebody because they are ANA positive? That tells you, or that tells us, that what is being treated as a report, and what, although it might be exciting, it's actually just something that will help you either confirm or refute your clinical diagnosis. Right? So the ANA positivity is not something that you call us for. The ANA positivity helps us in making a diagnosis, but the clinical features of why the problem has come, or why the patient has come to you, is something that you call for. Okay. So, like I said, firstly, antibody testing must be clinically driven. We see very often that just because you don't find something, an antibody is sent, and that becomes a huge problem. So we, especially in ICUs, especially in POs, etc., where there are no clinical features, you're not really suspecting any particular disease. Sending off a large number of tests is a problem, because just by virtue of statistical chance, one or two of 35 to 40 tests will come out to be positive. Right. So one must think of why you are doing this test. Is it aligned to my clinical suspicion? Am I suspecting something before doing this test? And what will I do if this test comes out either positive or negative? And there was this very interesting study where, if you look at lab reports that are sent to the lab, most of the errors come from something that are called the pre-analytical phase. So before even the analysis is done. So laboratory medicine are pretty objective in doing self audits. They'll say where we are going wrong, which machines are going wrong. We need to maintain quality assurance, something that we clinical physicians never do but should do. And what they've found in their audits is that most of the problems come before the sample actually reaches the lab, which is the pre-analytical phase, which is a polite way of their telling us that you're ordering tests wrong. So pre-analytical means that the clinician's decision is wrong, and that leads to a lot of laboratory errors. Secondly, within this principle is to say that autoimmune disease is not, or autoantibody is not a sine qua non of autoimmune disease. There are multiple diseases which are antibody negative. You have a small list on the right. Psoriatic arthritis, polymyalgia rheumatica, about 50% of inflammatory myositis are ANA negative or antibody negative. Does not mean that they don't have an autoimmune disease. And the patient should not be deprived treatment or should not have diagnostic delay just because you feel that an ANA came out to be negative and therefore they don't have an autoimmune disease. I mean, there are places where one thing shows vasculitis, one investigation demonstrates that there is tissue inflammation, but just because the ANCA is negative, they are not treated with immunosuppressant. That should not happen. So the amount of importance that you give to an autoantibody diagnosis needs to be tempered on the prevalence of antibody in the disease that you are suspecting. So, for example, if you suspect autoimmune disease in general, in a patient with psoriatic arthritis, obviously everything is going to come out negative. But if you are suspecting psoriatic arthritis by reading and by looking at the clinical pattern, then you may want to send a rheumatoid factor just to rule it out. But you are not going to be surprised that it's negative, and you are still going to start treating, right? Secondly, we need to think about what added utility a test provides. So, for example, I have a patient with lupus. You see this girl that we had in the KEM pediatrics department about a few years ago. I mean, she still follows up with us. If you look at the face, there is a very, very classical malar rash. You don't see that kind of malar rash these days because they are partially treated often. If you, I mean, standing in the door of the ward, I could see that this patient has lupus, right? And then when you went into her history in a little more detail, we saw that there is arthritis, there is rash, there is hematological involvement, there is renal involvement, etc., etc. So, what utility does an ANA in this patient provide me? Truly speaking, not much, because the diagnosis is written on her face. The utility, if at all, is documentation and insurance, all of these things. So that is the utility. If this patient was truly hard pressed for money, I would not even do any. So when will the test be of diagnostic utility? It's good to think about these annoying terms that we read in our entrance exam preparation, which we hate. So sensitivity and specificity of a test. I don't know how many of you remember, but what is the sensitivity of a test and what is the specificity of a test? Sensitivity is how easily you can pick out a person when you're screening. Specificity is how specific that test is for that particular disease and is not catching other problems. And then with these two parameters, you can calculate two more parameters called positive likelihood ratio and negative likelihood ratio. I'm just going to show you a few examples because these are things that you can use at least at the starting clinic to set your intuition on how to use testing. And it doesn't have to be only for autoantibody testing. You can use these for any test for that matter. So just remember these numbers. You don't need to remember all, but let's say you're taking ANA in SLE. It's a sensitive test, so you'll be able to pick out most SLE, 93% and by immunofluorescence and 57% specific, not very specific. And then I've just used these formulae to calculate a positive likelihood ratio, which is around 2, and a negative likelihood ratio is about zero point 0.1. So you just need to remember these two numbers. Um, Take another test in SLE, anti-SM, which is done by ELISA. Here the sensitivity is not much, it's 25%, but it's a far more specific test. And then you have a positive likelihood ratio of 5, and you have a negative likelihood ratio of 0.7. Okay. So take this girl that we saw in the pediatrics ward a few years ago. She had, like I told you, everything under the sun. And now you're going to do a test. Mm, you'll you'll find these kinds of nomograms which are on the right. You can just download them also, or this reference that I have given from the World Journal of Methodology. It will also have them. What you need to do is first fix a pretest probability in your head. So let's say I want to think about this patient, what probability of lupus do I think she has? So I would say 95 to 100%. And then from that, you pass the line through the likelihood ratio. So if you get a positive test, so through the positive likelihood ratio, and when you take that line towards the second vertical line, you will find a post-test probability, which is truly telling you how much that test has helped. So this patient, if I have a 95% pretest probability that I'm pretty sure that this patient has lupus, from 95, even if it's a positive ANA, it will pass through 2, and the likelihood is going up to 98. So here the positive ANA will not help me too much. From 95 to 98 is a small thing, and like I said, if they are hard pressed for money, I wouldn't really press upon them to for this additional value of the test. If, however, it's a negative test, then I'm going to pass it through. Where was this? Okay. So again, now these patients in lupus have not the very classical rashes, right? So you can have psoriasiform rashes, you can have just palpable purpura, you can have very different rashes. So then the pretest probability is not as high as 95% like it was in the initial patient. So you have patient with only fever, or if you have patients with only ITP or those kinds of things, or only brain involvement. So these are the kinds of patients where testing truly helps. For example, you have this girl who has a pretty short history of a rash, but she's had muscle pain before that, and then you also find some abdominal fullness and serositis on ultrasound. So this could be something like a dengue, it could be a viral infection, but it also could be lupus. If you look at criteria, it can fit in. So now let's say the pretest probability, it could be 50% viral infection, 50% lupus. And now if it comes out to be positive, that same test, the pretest probability, the probability is going up from 50 to 70. Now that is a truly significant jump, right? Here is where the ANA has helped you. Or more importantly, if the test is negative, then the probability has come down from 50 to 10. So again, you are far more confident in ruling out that this is lupus as compared to as compared to a viral infection. So this is the kind of clinical picture where you are not fully sure. That is when there is maximum utility of doing a test. What if you had done an anti-SM directly in her? So what if you had done a ANA blot directly? So suppose it came out to be positive, the positive likelihood ratio was 5. So now you have a post-test probability of 80%, which is better than what you had with an ANA. But if it comes out to be negative, then it just goes through 1 and it remains at 50. So absolutely zero difference from pre-test probability to post-test probability. And that's the sort of definition of a completely useless test or a waste of money, where you have not made any difference to your clinical thinking based on a test. So that becomes a problem if you do a specific test right at the start. What if you had done this, where you had done an ANA first, which is just cheaper test by immunofluorescence, then your pretest probability from 50 went up to 70, and now you do an anti-SM. where if when you do an anti-SM, your pre-test probability is already 70. It's already gone up by the ANA. So from 70, now you do a specific test. If it comes out to be positive, it's almost confirmed the diagnosis. And if it comes out to be negative, um, even then it remains at 70. So that goes to help you that there's still a possibility of lupus. It's just that they are anti-SM negative, right? So what I'm trying to derive at, and that's how most guidelines will tell you, and that's the answer to the question that somebody has asked just now, that would you do an immunofluorescence or would you do a ELISA? You would do a sensitive test first, and immunofluorescence is the most sensitive. So you would do a sensitive test first, and if it is positive, depending on what you're suspecting, you would do a specific test. Because if you do a specific test right at the start and it comes out to be negative, then there's a higher chance of missing a patient. Okay. Point number 2 in ordering is that parallel testing is a bad idea. They are available all throughout, and which is a bit of a problem. So we had this patient in the Sassoon Hospital medicine OPD. They have nail changes, they have asymmetric oligoarthritis. You can see a couple of joints being involved, not all of them. And you see this rash which he had on the back. What is your diagnosis? So my diagnosis was psoriatic arthritis, because there's plaque psoriasis and asymmetric oligoarthritis with nail changes. What tests would I do? I wouldn't do an antibody test at all, because psoriatic arthritis is not associated with an antibody test. If there was a gun against my head, I would do a rheumatoid factor, because for classification criteria, you have to demonstrate that rheumatoid factor is negative according to the Wrighted classification criteria. What this patient had come with, so they were being treated somewhere outside, is this terrible thing called an arthritis panel, which will test everything under the sun. So it'll test rheumatoid factor, it'll test complements, it'll test ANA, ANCA, whatever, what have you. And then this patient had an anti-streptolizino, which was slightly high, which can be even due to a streptococcal throat infection. There was some ANA cutoff. Complements were high. They were not low, but they were still marked as bold. And because of this test, what this patient was getting was penicillin prophylaxis and steroids. Steroids because one ANA was high, and penicillin prophylaxis because anti-streptolizin O was positive. Both of which are a bad idea, because there's no real need for penicillin prophylaxis. They're just getting multiple injections, and you're giving steroids to a patient with psoriatic arthritis, much higher chance of psoriasis relapsing or getting worse after you taper that. So here is an example of a patient being actually harmed because of unnecessary testing. Not only were they getting incorrect treatment, but it was possibly harmful treatment which could have worsened the disease, which is a bad idea, of course. The third, I said this at the start, was that the antibody is not a disease diagnosis. Just yesterday, I received a message from a resident saying, what do you think the patient has based on the antibody test? So that is not the answer of, or that is not even a question of why I need to think about what the patient has. The tests are in front of you. The disease is diagnosed clinically, the antibody helps. So for example, this patient who you remember, who has come again and again, they did an ANA blot in her, the anti-Rho came out to be positive. And from the next day, I saw in the papers that people started writing a patient with SLE with a patient of SLE with Sjogren's syndrome. Did she have any clinical features of Sjogren's? Was there dryness? Nothing at all. And if you see the table in Harrison's, this is picked up from, I think, the earlier edition of Harrison's. 30% of lupus will have anti-SSA positive. So just because there is anti-SSA or anti-Rho does not mean that there is Sjogren's also. In fact, if you see SSA in particular can be virtually present in most of the connective tissue disease. So do not label a patient because there's an antibody. Fourth, antibodies are very, very rarely used for monitoring. Do not do ANAs every time a patient comes to you. Do not do rheumatoid factors. So there was this lady who was my patient. It was her favorite activity to get a rheumatoid factor done every 2 to 3 months, and then she used to come to me with a lot of alarm saying that my rheumatoid factor has, or happiness sometimes when it went down from 320 to 145, but then it went up again to 345. Um, Whereas if you looked at other joint parameters, which is what we are treating, we want her not to have swollen joints. Um, she was doing not as well as I would have like to, but from 13 swollen joints, she had come down to 4 swollen joints. So she was doing okay, but her main problem was the rheumatoid factor. That does not have any bearing. It is not prognostic, so we don't need to do it all the time. The only two real situations where we would like to do antibodies to monitor is anti-dsDNA in lupus and in lupus nephritis in specific, and anti-PR3 in GPA, Wegener's. So those are the two antibody tests that are useful for monitoring. Otherwise, they are not useful for monitoring. They are diagnostic tests. Fourth, if you have a positive test, don't be trigger happy with steroids and immunosuppressions, especially when you're monitoring. Right? So let's say you have this patient with SLE. When she comes to you, she doesn't really have any new clinical features, but you are acting true to a textbook and monitoring her complement levels and anti-dsDNA. And this time you see that her complements have dropped and her anti-dsDNA has increased. So what would you do? What I've seen being done is the first thing, often, rarely the third thing, which is increase steroids. We are very trigger happy about steroids, is what I've seen. But you need to take these tests in context. If you remember, there is no clinical change. There's no new urine sediment. There's no new symptom. All that there is the complements have dropped. And we have the Toronto lupus cohort to look to in answering such questions because they've done things like monthly anti-dsDNA levels. And what they found that if there is a increase in dsDNA or if there is a drop in complement, then the flare rate increases. So, but increases from what? So if any patient has about a 20% flare rate in the next 3 months, and the flare rate went up from 19% to 30%. So it's still that 70% will not flare, only 30% will flare. So all really that you need to do is monitor maybe a little more closely in the next 3 to 6 months to see that if they are actually flaring. And if they do flare, then you want to treat according to what the flare is like. So if it's a renal flare, then you would maybe pulse IPMP. That's not a problem. But you would wait or monitor for a flare because 70% are not going to flare. Only 30% are going to flare, as you see in this. And fifth, the UK is a useful place for these things because everything is funded by the state, and therefore you have to very, very critically appraise what you are ordering because these tests are expensive. So we did that when I was resident in 2015, where we just saw what all anchor testing the laboratory at SGPGI got. So we received about 1,600 samples, and out of that, about 100 were positive, which is fine. It's a small number, but that's true throughout the globe. The problem was that even within these 108, only about 25% or even less than that were actually anchor vasculitis. And look at the patients who are not anchor vasculitis. Like, for example, you have 5 patients with tuberculosis. That's a problem because if you misdiagnose a patient with tuberculosis as anchor vasculitis, then you're going to immunosuppress them and make them worse. Or CKD, for example, had anchor positives, etc. The NHS has this gating policy where to be able to order an anchor, you need to say that at least one of these 8 things is positive, is checked, and only then can I order an anchor. And we went back to all these 1600 files and saw that, not the 1600, the 108 people who had ANCA positive, and said that if we had applied the gating policy, all the patients with ANCA vasculitis would have fulfilled at least one criterion. And in the patients with no ANCA vasculitis, that was the false positives, about half of them did not fulfill any of these criteria. So at least we could have saved those 40 people from having a false positive test. So it might make sense for us to think about doing a gating policy for tests, or in your mind, just say that only if these things are present will I order a test. Right? So to take home, first, when you're suspecting a connective tissue disease, lab testing has very different goals. You must make sure what you're doing the lab test for. Is it for diagnosis? Is it for prognosis? Is it for monitoring? Secondly, a test should not be done without a clinical reason. Thirdly, think about how much delta information it's going to provide. And like you saw from the patient with psoriatic arthritis, shotgun parallel testing was a bad idea. It can harm patients. Again, appraised test ordering can also help patients in not spending money which they should not be spending. Thank you. And I think we can open for questions. And
Yes.
You have my email. So if you feel that you want to ask something later, that's fine.
So thank you. Thank you for an excellent and very practical session. You have made the interpretation of a rheumatology investigation much clearer and clinically meaningful for all the students. And we'll now move to the question answer session. There are some questions. So how do you prefer doing ANA by ELISA or IFA? You have answered, but to summarize in
So that question was answered.
yeah.
But again, it depends on the goal. So do you want to screen a patient for a connective tissue disease? Then I'd prefer an ANA by immunofluorescence because it's a sensitive test. When I would do an ELISA is when I want a specific antigen within the ANA to be positive. So if I want to see if it is anti-dsDNA positive or monitor a patient for anti-dsDNA later, then I would do ELISA.
And second is how to approach a negative ANA IFA but a positive ANA blot for a specific antibody. Is this a rarity?
It's a logical fallacy, right? Because an ANA by immunofluorescence has to be positive if one of the antigens with inside it is going to be positive. So there are some specific examples where ANA by immunofluorescence is negative, but you get the Rho positivity because Rho is an antigen that can go inside the cell and outside the cell. So maybe you got the ANA by immunofluorescence while the Rho was outside the cell. So that is known. But yeah, they are rare, and these are situations where you should really go back and think what you're treating or what you're really suspecting. You should look at the titers or see what kind of reports that you are seeing on the ANA blot is. If it's very, very mild, just above borderline, then it's positive, probably a false positive just because there's so many antigens being tested. So there are multiple troubleshooting things that you could do, but at least it should raise your antenna that something is not correct.
So suppose if you are suspecting autoimmune hemolytic anemia patient, but first if ANA blot is negative in the first
Yeah.
admission. So,
Yeah.
but second admission patient again admitted with the hemolytic anemia. But whether we
Yeah.
have to require ANA blot again or
So
whether it,
firstly, I would not do an ANA blot directly because the ANA blot, like we said, is only looking at 15 antigens. So if the ANA is positive, but the antigen is against one of the 100 to thousands of proteins within the nucleus which are not covered in the ANA blot, then you're completely missing that ANA if you do an ANA blot directly. So that is one. And secondly, if you would do an ANA repeat only if there is a change in clinical features and you're truly suspecting that they are evolving into something else. Because there are many ITPs only or many autoimmune hemolytic anemias who are ANA negative. And if they are only autoimmune hemolytic anemia with ANA negative, just having an ANA positivity is not going to change much of your treatment. So if you feel that now they've developed arthritis or they've developed nephritis, and I want to make sure that I want to recheck the ANA or see if the antibodies have changed, then clinically you might want to do that.
Sir, if the acute autoimmune fulminant hepatitis and the anti-SM RNP has come positive, but ANA-DSDN has come negative, and even anti-LKM is also negative. So whether we should consider it's a SLE with a fulminant hepatic failure?
If there are no other features of SLE, then they are not classifiable as SLE just because an anti-RNP is positive. An anti-RNP is a very commonly seen false positive test. So if it's a patient with SLE who has now hepatitis, then I would treat it as hepatitis in a patient with SLE. But just because a patient with fulminant hepatitis who has no other clinical features of SLE, there is no real reason for you to suspect autoimmunity in her. And just because an RNP is positive, I would not go ahead and immunosuppress unless I have maybe biopsy evidence that this is autoimmune hepatitis and not otherwise.
Thank you.
Another question in chat box. Sometimes UNSM RNP comes positive in clinically SLE patient. How to elicit that, or what is the significance?
The significance is nothing. I mean, you are treating clinically, you're treating them as SLE. So U1 RNP means that you may want to label them mixed connective tissue disease, but again, what is seen in mixed connective tissue disease is that the mixture is in series. So, for example, they'll behave like SLE for a few years, then they'll change over to myositis for a few years, they'll change over to systemic sclerosis. So, if they are behaving like SLE now, you treat them as SLE. The only help that an RNP, SMA RNP positivity has given you here is to say that you want to keep your eyes and ears open in future to say that suppose 10 years from now, if they present with dermatomyositis kind of features, you're not going to be surprised because they can, because it is probably a mixed phenotype.
So from student point of view, I just want to ask one question. Many a times we get patient with AKI, RPGN like picture, and we get ANCA positivity, PR3 borderline or positivity, but biopsy is awaiting or not able to get the biopsy. So with that single PR3 positivity, do you consider that as ANCA, or you wait, or you repeat by another method? What is your way of, because
if it's a very, very obvious positivity, and like for example, a patient with vasculitis can present as rapidly progressive glomerulonephritis with RPRF. So that is not unusual. So if you are reasonably certain that there's no other cause, no obvious infection, all of that, then you can start treatment. It depends on the urgency of the clinical situation. So if it's diffuse alveolar hemorrhage, I won't really wait for a lung biopsy if an anti-PR3 is positive because it fits and there's no real other reason. It depends on how urgent you feel that the treatment is also. You can stop steroids later if you find a different reason, but it doesn't mean that you should delay treatment until more damages occur.
Yeah. I think there are no more questions. Natasha ma'am, you want to ask anything?
Are there any words just for students? Any word on the newer antibody DFS70?
DFS70 is, yeah, we get a lot of that. That's one of the patterns in both an immunofluorescence and you get it in an ENA blot also. And that is actually something that is not associated with antibody, with connective tissue disease. So we need to take that with a lot of salt.
So that is something that is protective kind of.
Yeah.
So
It's a very good lecture.
Yeah. So I think we are
Okay.
over with
We
questions.
can. Yes.
Yeah, we
Okay.
can conclude
Good.
the session.
Sure.
Thank you, sir.
Okay.
Thank you.
Thank you.
Thank
Thank you,
you.
Natasha.
Thank you.
Thanks.
Yeah, thank you.